Hello, everyone. Welcome to the session. So the presenter today is Dr. Justin Moore. He's an infection disease and antimicrobial stewardship clinical pharmacist at Northwestern Memorial Hospital in Chicago, Illinois. Justin is a graduate of the University of Georgia, where he earned his Doctor of Pharmacy degree after receiving a Bachelor of Arts from the University of Virginia. He completed his PGY1 and PGY2 ID pharmacy residency at Northwestern Memorial Hospital, and his current role includes infectious disease clinical consult services in immunocompromised hosts, antimicrobial stewardship, and clinical outcomes research. So thank you so much, Dr. Moore, for presenting today.
Of course. Thank you for joining, everybody, and thank you to the Planning Committee for having me. So today we're going to talk about the value of diagnostic stewardship and how we can use it in partnership with antimicrobial stewardship to really optimize kind of use of these agents and hopefully improve patient outcomes. Here are the learning objectives. I'll give you a second to read those. And of note, I have no conflicts to disclose. All right, so stewardship, I think, a lot of us are used to this term now. It's really the job of supervising or taking care of something. So antimicrobial stewardship, we really are using this to protect the antibiotics that we currently have from resistance and encouraging the use to be able to use them in the future. So that's going to include things like making sure that there's no bug-drug mismatch. So choosing the most narrow spectrum for the correct indication, using the appropriate dose, and continuing that antibiotic for the most appropriate duration. And then we've got our diagnostic stewardship, which is really improving ordering, collection, processing, and reporting of those tests, and using expert interpretation both from the lab side and hopefully a clinician standpoint to help guide therapy, again, for the most appropriate agent based on that information. So who's making this decision and who's helping to supervise these agents and these tests? It's ID clinicians, so pharmacists, physicians, APPs. We've also got other team members, so prescribers from primary teams, the micro lab, and obviously their expertise is instrumental to making this happen. Hospital epi and infection prevention, key players, as well as informatics and hospital leadership. So all of these people really need to be involved in order to optimize the use of these agents and tests. And again, really the ultimate goal here is to optimize patient care and reduce the risk of resistance. So how does this happen? So here we have a kind of nice schematic of what's involved in the diagnostic pathway. So obviously the patient initially comes in, concerns for an infection, a differential diagnosis is worked up, and then specimens are collected at the bedside and then sent to the microlab for evaluation. At that point, processing occurs and results are reported from these like benchtop efforts directly to the clinician for interpretation. So each step in this process, as you can see, is essential. And many of you can already tell that there are going to be opportunities for optimized stewardship practices like throughout this diagnostic continuum. So again, from the lab side, from the primary team, from the stewardship standpoint, we all can pitch in and help optimize care here. So we often talk about the rights of antimicrobial stewardship and how important it is to select, again, the right drug at the right dose for the right duration. This can apply to diagnostic stewardship also. So we need to establish the right diagnosis by performing the right tests and collecting the right specimen. Hopefully achieving source control is also something that we'll be able to do by obtaining that correct specimen. You can see from the lab standpoint, the pre-analytic phase up at the top with the microscope. So that applies to what happens before a specimen is received by the lab. The analytic phase includes the processing and testing of those samples. And then the post-analytic phase includes like reporting and decision-making, in this case, related to antibiotics, obviously. From there, we can tailor our empiric therapy down at the bottom, so the pill and the IV bag, by using these results to de-escalate during the definitive phase. So this supports, again, how partnership is really essential to ensure patients receive the most appropriate therapy by identifying an appropriate diagnosis. So, what do people really need? We need to think of who is our end user. In this case, it's mostly the clinicians that are going to be making decisions for the patient. So these clinicians need accurate, timely results. So that timely information needs to be reliable and can be acted upon quickly. For example, if we can identify resistant genes in a blood culture within a day or a few hours versus multiple days, that's going to, greatly improve that information getting to the bedside and then that clinician being able to make a decision. It also needs to be relevant information. So does it pertain to that differential diagnosis? So we want to make sure it's tailored to kind of what our thought process is and why that patient's presenting to the hospital. It needs to be clear and interpretable. So we have a ton of information, obviously, in our electronic health records. We've got alert fatigue and distractions everywhere. So making sure that it's standardized, it's easily understood, and there's no ambiguity to the results. That can also help clinicians in decision support. And then speaking of support, so expertise, again, from both the lab standpoint and the ID and stewardship clinician. So we as specialists can help provide insight into the methods, results, and clinical guidance surrounding that information. The value of stewardship here, so it's estimated that about 20% of diagnostic tests are overused or inappropriately ordered. So I know on the stewardship, antimicrobial stewardship side, we have results upwards of about 50 to 70% of antibiotics are used inappropriately or unnecessarily. And so we see that on the diagnostic test side as well. So those reasons can include incorrect diagnosis or lead to incorrect diagnosis, unnecessary or inappropriate treatment, which would obviously disfavor kind of our ASP outcomes as well. They can also lead to prolonged hospitalizations and increased healthcare costs. So again, really why this matters to help kind of make this more effective for us as clinicians and also improve patient care. One thing that we can do to help, and I think a lot of institutions are getting on board with, is the use of diagnostics, rapid diagnostics. And this technology can, really improve getting that information again to the bedside. So they're highly sensitive tests. They result in faster results. And they're critical to, again, optimize patient care. But one caveat, we really do need to assess pre-test probability. So by estimating the prevalence throughout the community and taking a patient history that's really thorough and in depth, we can help use that in combination with these rapid diagnostics to come up with an appropriate differential and hopefully a definitive diagnosis. So this is an example actually from AAC. So this is Fagan's nomogram. So this helps put that pre and post-test probability into context for interpretation. So it relies on this likelihood ratio. So again, prevalence here would be that pre-test probability on the left, and then our predictive value is going to be that post-test probability. And using the likelihood ratio, which helps put into reference, again, the probability that a test is correct to the probability that it's incorrect. That can help guide us as clinicians what to do with the results that we get. So there's some evidence that supports getting a thorough patient history is the most helpful thing that we can do to actually figure out a definitive diagnosis for a patient. It was upwards of about 70 to 80%, depending on which study you're looking at. So really, this is where ID can shine. Get that patient history about, which birds the patient's encountered, or reptiles that a patient's had, hot tub visits, et cetera. So those nitty-gritty details that ID is so good at capturing can really be put to use here. When should we be sending these tests? So they should be used in cases of intermediate to high pretest probability. So obviously, if we have something that's very low probability, that could lead to a false positive. So for example, the classic case, if someone who doesn't have a uterus is possible, or excuse me, pregnant, that would likely be a false positive and lead to unnecessary, diagnosis in that case. But for infection, it would be unnecessary treatment and testing. And then for those with very high probability, so we're already pretty convinced that that's what the diagnosis is or what the issue is. So we just need confirmation. If you got a negative in those cases, it could be a false negative and then lead to mistreatment or treating regardless. And then again, unnecessary testing in those cases. So some common infection related examples would be something like C. diff testing without diarrhea being present. So if a patient is, colonized, we could have a positive PCR results, and in those cases, it may lead to treatment if we don't have any secondary confirmatory testing. So that is something that we would not want to be doing. Likewise with urine. So without urinary symptoms, urine culture should not be sent, and that could lead to overtreatment and misdiagnosis. So I've broken this talk up into kind of the 3 phases from the lab standpoint, so that pre-analytic, analytic, and post-analytic. So that will help kind of give you a frame of reference for where we'll head throughout the discussion. So again, that pre-test, we really need to be looking at some factors that may influence things. So before the sample is even received by the micro lab, so things like community prevalence, a patient history, clinical presentation, and symptoms, those could all go into whether the test is even sent or not. Then we've got things like order placement. So is it the correct test that's ordered? Um, is it something that, maybe isn't appropriately labeled and leads to confusion? So one thing that we see at Northwestern is for cytomegalovirus or CMV, we have clinicians order like an IgG or an IgM when really they're looking for a quantitative viral load. So this could lead to, resulting in unusable results or delays in care. So really want to avoid that and make sure that our orders are intuitive for users, again, with the clinician in mind. The sample collection, so is it the ideal specimen? Do we have enough amount, and is it high quality? So things, especially with like urine, making sure that it's not directly from a catheter bag or anything like that. And then preferably prior to antibiotic exposure, especially in those stable patients with like chronic or acute on chronic osteo that aren't at high risk for decompensation, we should be able to wait and get those cultures prior to starting antibiotics. And lastly, we want to make sure it's timely and appropriate transport to the lab. So making sure that that specimen isn't sitting on the counter for 6 hours on the floor before it's transferred over. That could lead to some difficulty with interpretation or incorrect results. Also, clinician education is crucial here. So partnership from antimicrobial stewardship, infectious diseases, informatics, and the lab to really educate on these best practices to limit the use and ordering of inappropriate tests or sending these suboptimal samples. So things that we can do within the EHR to help provide electronic decision support is build in order sets, clinical pathways, and educate on them. So this is where your ASP partners can help to provide in-services, guidance documents, or nudges within the EHR. That should be, again, that collaborative approach, which will help optimize the sending, the ordering, and the interpretation of these results, and really streamline the processes and prioritize which tests should be used based on kind of what you see at your hospital and what the differential diagnosis includes. Another thing that you can also do is like a lab test restriction. So again, going back to our C. diff example, which we'll touch on, if a patient doesn't meet criteria for screening, i.e., no diarrhea or lack of high volume, high output stools, it may be a reason to block that test because it could result in a false negative or false positive. In that case, probably false positive, and then lead to overtreatment or inappropriate treatment for that patient. It's another crucial thing to do is set clear expectations for your clinician. So when possible, have an opportunity or have a platform to share this information. So it cuts down on questions to the lab. That communication burden is huge. Obviously, our lab colleagues are getting a ton of calls per day. So if we can limit that and free them up to, run these tests and do other things, that can optimize care and optimize the information getting back to the clinician. So this is something that we do at Northwestern. I'm sure a lot of centers do this, but we have a lab handbook, which, it's electronic. People can search based on whatever test they want to run to get additional information. So the example listed on the screen here is posaconazole. You can get a quick overview of things. So what type of specimen we run it on, what's the collection tube, et cetera. And any like special instructions, again, to ensure during that pre-analytic phase when it's being ordered, collected, and sent to the lab, that everything's kind of done in an optimal fashion. This is just the full kind of explanation again for that POSA, but we added some additional criteria. So aside from the specific instructions for getting it to the lab, we also have kind of what's the reference range. So that can be helpful for clinicians when they're interpreting that, as well as like the availability and turnaround time. So when do we run this? So we run it Monday, Wednesday, Friday at 10 a.m. That way, sharing this information can cut down on frustration from clinician because they think that it's a delayed result and may cause them to call the lab, again, putting more pressure and unnecessary communication to the lab. but it gives you the estimated turnaround time as well. So 2 to 3 days in this case. So that way folks know, okay, I ordered it on a Monday, it's ran at 10 a.m. I should get that result back by like Wednesday. If at, Friday you're still not having a result, maybe that's a time to call the lab. But again, helping kind of the end user or the clinician in this case by sharing this information is really a net positive for everybody involved. So expectations are clearly set. So leveraging the EHR, so we really want to use our technology to make it easy to do the right thing. So it's important to emphasize kind of tests that you use all the time. So preferred or frequently ordered tests, and then look at how you actually have them listed in your EHR. So they should be named clearly with, again, the clinician in mind, to help reduce any uncertainty and avoid ordering of those incorrect or inappropriate tests. They should be prioritized. So have a system that allows you to, change the order, change the name, add additional synonyms. So when people are searching, especially things like misspellings, sometimes that can influence how tests appear in the EHR. Um, and then when you're deciding like how to include them, how to show them in the HR, have clinicians weigh in. It's important to get that feedback to know when and why they're ordering it, if to identify if there are ways that we can make it easier for the clinicians, or if they're running into barriers with ordering, et cetera. Again, to kind of reduce the workload on both the clinician and the lab, and help improve that optimization of test ordering. Also redundancy, that's a big one that we see where you've got one test and there's 6 different ways that it's in there. Really making sure that that's streamlined to help kind of prevent any errors is a good practice. And then again, really take a look what's utilized, what's not, and try and streamline that when possible. So one example that we've got here is a vitamin D order. So this is actually one of our ID and ASP physician colleagues at Northwestern. Her brother was actually involved in the study. So this was a time series analysis of 2 academic hospitals assessing the influence of computerized provider order entry, or CPOE, on the ordering of vitamin D tests. So they noticed that they had a real uptick in one particular vitamin D test, and some complaints about, interpretability and how to use this. So they had one test, vitamin D 25 hydroxy, which identified a vitamin D deficiency. Another one, vitamin D 1, 25 dihydroxy level, which identified rare endocrine issues or disorders. And they found that rarely used, or should be rarely used, 125 dihydroxy level was being ordered quite frequently. Um, and as a result, they did a crossover study and pre-post to help identify, what CPOE optimization they could really do to help encourage users to select the preferred product. So here they were able to do that, and they identified that there was a lack of familiarity. So they had similar names, didn't have context. They didn't really know how to use these tests. So again, getting the clinician involved to help know why these tests are ordered. So as a result, they ended up adding the purpose and frequency. And another thing they took away, that sorting, it influenced it somewhat. So putting that preferred test to the top of the list was somewhat impactful, but not as much as really adding that context. So purpose and frequency was more significantly beneficial for selecting the correct product. So you can see here they renamed them to common and rare, and they also included the indication for vitamin D deficiency versus that endocrine disorder. And as a result, they saw that high volume of inappropriate tests go down, and it was significantly decreased, and the preferred test was ordered more routinely. So this is just one example of making it easy to do the right thing. So again, involve your clinicians, assess trends in use, and really remove any barriers to ordering the inappropriate test, because it can cause issues for the lab and drive up costs and result in unhelpful information. So this is the example largely of our CDIF protocol or algorithm. Again, I know a lot of centers have this, but this is one of those diagnostic and clinical pathways that can be used to optimize ordering. So knowing which clinical criteria should be included in order to send that test. So here you can see, the patient needs greater than 3 watery stools. They need to have no alternative explanation, so no laxatives, no contrast. and then no previous negative result or less recent positive result. So really helping clinicians know when to send it. And then in the bottom buckets, we also provide, based on the result, what's the interpretation and recommended treatment. So adding kind of the comprehensive view. So from initiation, the patient comes in, to ordering with kind of clinical criteria, and then what would be the preferred treatment. So you can see here, based on the PCR and then reflex toxin testing, what would be appropriate for a negative patient versus a toxin positive patient in terms of treatment. So these things are, tools that we can use to really optimize that partnership between lab and stewardship. Again, enhancing efficiency, decreasing the amount of inappropriate tests that are used. More than anything, reducing that uncertainty when that positive result comes back, but a patient doesn't have diarrhea. Is that leading to treatment, or can we ignore the result? So again, going back to our pre-probability there. And then interpretation. So really providing education to allow clinicians to feel empowered to know what to do with the information once it's received. So another one that I know we all struggle with is treatment of asymptomatic bacteriuria. And that starts with optimizing when and how these tests are sent. So I'm sure everybody on the call knows, but really urine culture should not be sent outside of urinary symptoms unless the patient's pregnant or they have a planned urologic procedure, and maybe some wiggle room with renal transplant patients within that first month of transplant. But there's some debate on, around the appropriate window for treatment for those patients. There are studies that show that upwards of 50% of patients have been screened on admission and had that UA sent. And then that UA being sent leads to, a positive urine culture and could promote inappropriate treatment of these asymptomatic cases. The Advani paper, which is cited here, is a really good one, and actually includes a nice framework to consider breaking down the UA into various panels. So there are a bunch of different reasons that a UA may be sent, so renal, metabolic, inflammatory, malignancy, etc. But they give a nice guide of maybe how to rethink this to prevent that urine reflex or urine culture reflex from happening and then leading to inappropriate treatment of these patients. Another thing that we can do as ASP clinicians, and again in partnership with the lab, is really scanning protocols and order sets to determine where the UA and urine culture could be included. So we've done an exhaustive review, and you're finding it in all of these outpatient settings, or maybe one specific clinician is continuing to order it, but they didn't even realize they were doing so. So using this information and assessment to identify hotspots and then perform outreach to those users that are, frequent users or maybe frequent prescribers. So that would be a good thing to do, especially in areas that we would assume do this routinely. So the ED, surgical procedures outside of that GU system. So something like a joint replacement or cardiac procedure, we shouldn't be getting UAs and urine cultures on these folks unless they present with symptoms. So this is something that we can do to kind of optimize these tests being sent, and again, downstream antibiotic prescribing. So this is just for your reference, but again, going through it. So pregnant and invasive urologic procedures where we're having tissue disruption. So from the IDSA ASB guidelines from 2019. So this is who should be screened and tested. And again, maybe some justification for kidney transplants within the first month, but otherwise we should not be routinely screening nor treating these patients. So again, educating your prescribers and clinicians to really avoid this practice to help cut down on tests being sent to the lab, as well as antibiotic prescribing. So this is, again, kind of supplementing that message with clinical education. So this is a guidance document that we have on our ASP website, and really spelling out kind of everything that they need to know, but giving them a highlight of the key information. So here, what I have in the gold box is, again, the message that we need to say over and over, it seems, but really, unless the patient's symptomatic, we shouldn't be treating this. And then spelling out what those symptoms are. So dysuria, frequency, urgency, suprapubic pain, flank pain, fever, etc. So helping the clinician know what to look for, and they can use this as a checklist as they're going through. Okay, does my patient have this, this, this? If not, then hopefully that cuts down on them actually sending that test and including it on the differential. The other thing that I just wanted to point out here, obviously this is a huge challenge in, an altered elderly patient who's not that communicative. So we do give some additional nudging to say that, these patients, it's important to figure out an appropriate diagnosis for them because they may be at higher risk for adverse events associated with antibiotic use, C. diff, et cetera, GI disruption. So again, just a subtle nudge to help really make sure that people are coming up with the appropriate diagnosis. So now going into the analytic phase, again, this is the processing and testing phase of that sample once it gets to the lab. So this is where rapid diagnostics come in, RDT, or referred to it both ways. So RDT really helps to decrease the time to organism or pathogen identification. So again, we're going from several days for full ID and susceptibility to really hours for certain pathogen identification, and then maybe another day or two for susceptibilities. And that time is being, shortened and shortened, it seems, as more information and technology is being developed. That kind of rapid information allows us to optimize antimicrobial therapy a bit sooner. So again, we're acting on, day 1, day 2, rather than day 3, day 4, which can also have some benefits to the patient and the hospital. And by knowing what pathogen is causing these infections, we are able to tailor therapy sooner. So hopefully reducing that risk of adverse events and subsequent resistance. And then from an infection prevention standpoint, it's, a win for them as well, because we can hopefully remove isolation in cases once we determine that a patient doesn't have a resistant organism, and has the benefit of reducing transmissions for those patients once they are identified early as having one of those resistant orgs. So the role in stewardship, so really these tests are used and they should be, accurate. They should be quick for the technicians in the lab, so minimal hands-on time, cost effective, and result in those rapid kind of information and pathogen IDs. So they are recommended by IDSA stewardship guidelines. So hopefully potential for cost savings, decreased time to effective therapy, which we talked about, decreased antibiotic consumption, hospital length of stay, and mortality. Most of the data is actually in partnership with stewardship programs and interventions. So again, another place where that collaboration is key. And as we'll talk about, a lot of the data is really surrounding bloodstream infections. So I won't go through this, but this is from Christy Bertram, one of my colleagues at Northwestern. This is just kind of a summary table of a lot of the readily used RDT platforms. At Northwestern, we tend to use BioFire and then Cepheid Gene Expert, as well as MALDI-TOF, and then Vitec2 for some of our susceptibilities. So this is an example of how RDT can be used to help improve stewardship outcomes. So this was conducted by Tim Brook and colleagues, which was a meta-analysis of about 31 studies, including 6,000 patients with bloodstream infections. They showed that use of molecular rapid diagnostic testing resulted in significant reduction in mortality compared to conventional methods. They estimated that it was about a number needed to treat of 20. However, if you'll notice, so the top kind of bucket is with ASP, the bottom bucket is without ASP, and you can see those confidence intervals shift quite a bit once you remove that ASP intervention, and that's driving that reduced mortality. So by relying on expert interpretation of these results, ASP pharmacists and physicians can provide tailored treatment guidance to promote, improved outcomes, improved antibiotic use. And the benefit here was seen in bacteremia caused by both gram-positive and gram-negative pathogens. And they also saw a decreased length of stay by about 2.5 days, which can, be used to support reduced costs, increased patient turnover. By freeing up those additional beds, that's, obviously a win for your hospital leadership. And potentially could result in increased revenue to support expansion of ASP and microlab initiatives. So again, using this technology can hopefully help optimize patient care, but also optimize kind of our practice as well. So getting into the kind of post-analytic phase. So again, this is once the results are available, really sharing that information via reporting, and then what subsequent clinical decision-making happens from there. So these are the functions from IDSA stewardship guidelines from 2016 that provide really best practices for both the microlab and ASP collaboration. They include things like development of antibiograms, selective or cascade reporting, which we'll talk about. Treatment guidelines, so again, those clinical pathways are really key. Use of really widespread rapid viral testing, so things like our rapid pathogen panel, RPP, which we use at Northwestern, which is BioFire, and then Cepheid. And then things like rapid diagnostics for blood culture. So that is a key one. So that one is BioFire. So these are all things that we can do, and maybe when you're evaluating your program and your institution, be looking for these things as opportunities, if you're not doing them, to potentially start. So the biggest thing really, like we talked about before, is providing that actionable information. So these are things that we'll cover to hopefully identify ways, to optimize how that information is provided to the clinician to impact decision making. So that reporting, we'll talk about order comments as well as the guidance and education, and then we'll touch on some updated breakpoints from CLSI. So this is one that we, again, conduct at Northwestern, and I'm sure a lot of sites throughout the state do as well. But this is the blood biofire PCR, or BCID2. So this is something, just wanted to share kind of how we use this within our ASP workflow. So this comes through as an in-basket message report for us within the EHR that we check 2 to 3 times a day. And that's a pharmacist from our Antimicrobial and Diagnostic Stewardship team. Then we reach out to the primary team to help kind of tailor therapy at that point. And we provide additional education on our website, asp.nm.org, which I'll show in a second. We've done it in about 300 patients thus far. So we just launched this in March of this year. Early on, we've seen a reduction in anti-MRSA therapy. So people are very comfortable de-escalating, even in, hemodynamically unstable patients. Once we've identified that it's a gram-negative, really taking off that vancomycin or linezolid, and then also helping to improve with more timely de-escalation of, those broad-spectrum agents when we don't have resistance detected and the patient doesn't have a history of resistance. There's evidence to support this. So we talked about the Tenbrook paper. There's one specifically. So Allison Porter and colleagues down in Georgia. So they looked at the blood biofire with pharmacist intervention and found that it significantly decreased the time to therapy change, significantly increased changes to optimal therapy. So again, getting patients on the right therapy for them. So yay, stewardship win. And then reducing that vancomycin for contaminants. So when it was, a coag-negative staph, 1 of 2, really being able to de-escalate quickly to limit the patient's exposure to vancomycin and hopefully prevent adverse events as a result. This is something that I think we can also do. So order comments. So if you look at the third paragraph here, so we had some confusion where if you look at the target, so there's Enterobacterialis and there's also the specific pathogen, E. coli, Klebsiella, et cetera. When we first went live with this, folks were thinking that it was a polymicrobial infection. So we had an Enterobacterialis that was, not speciated, and then we also had an E. coli. So we had to educate on that to help clinicians understand that it's, identifying the family or order, but it's also identifying the specific pathogen. So that third paragraph here really spells that out for them. So when Enterobacterialis is positive, but there's nothing else, that would be indicative that that's, a more rare GNR. However, when it's positive with something like E. coli, Serratia, Klebsiella, it's more than likely that pathogen, and we should treat it as such. So again, just this one order comment and then subsequent education really helped to clarify this, and I think made clinicians feel more comfortable by reducing that uncertainty. So this is just an example of our results. We've got these available again on our website if you're interested. So the organism, any resistance genes that are detected, and then what our first and second line antibiotic recommendations would be, as well as any order comments. So something like a Staph aureus bacteremia, get ID on board. This has been really successful to empower both prescribers and pharmacists to know, when we get this result, how far can we tailor therapy? So before, when we would have Staph aureus reported from a blood culture, it would be, 2-3 days before we knew that it was MRSA. Now, with the lack of detection of that MEK-A gene, we're able to definitively say it's, or more than likely say it's MSSA, and getting patients even in the ICU down to cefazolin within a day is a huge win, and hopefully limiting kind of, again, that risk of adverse events for the patient. This is just our gram-negative panel, and it's a bit more exhaustive, but just wanted to share so you can see some of the details, especially nuances for critically ill patients, or if they have allergies, et cetera. These things should be considered. This is something that I don't think we've talked about today, but AMP-C is obviously something that we as pharmacists love to talk about, especially inducible AMP-C, thanks to the IDSA guidance from last fall. So we now have a little bit better, I think, data to help drive this in terms of our education efforts. But they've bucketed things into moderate to high risk of that overexpression of AMP-C. So Enterobacter cloacae, Klebsiella aerogenes, and Citrobacter frundii. So those are, again, that high-risk bucket, upwards of about 40% of resistance when exposed to early generation cephalosporins and other beta-lactams, aminopenicillins, et cetera. And then the other kind of classic spice, space, MySpace bugs, they've lumped into this low or uncommon. And really unlikely to overproduce this AMP-C, things like Serratia, Providencia, certain Proteus. And so we can more safely guide clinicians away from things like cefepime, meropenem when they're unnecessary. So this is something that we can do to help impact prescribing from a stewardship standpoint. And then really, sharing this information from the lab. So looking at your local resistance data and susceptibility reports. So this is our antibiogram, which again should be kind of developed in partnership with the lab. But you can see things like Serratia, again, one of those MySpace spice bugs that we used to be concerned about for inducible AMP-C. By looking at the susceptibilities, ceftaz, ceftriaxone, cefepime, we see they're all fairly stable. Which you may say, okay, it could be initially susceptible and then with exposure becomes resistant. But even looking at all isolates, most of ours remain at the lowest MIC. So we have that local data to help support those, national, international guidance documents. You see things like Citrobacter here. So the discrepancy between ceftriaxone and cefepime could be explained by the discrepancies within their species. So a Citrobacter cosseri versus a frundii, which we'll talk about in a second. And then things like Enterobacter, you see a clear drop off. So 93% susceptible to cefepime, 72% susceptible to ceftriaxone. So again, supporting that inducible AMP-C high risk for overexpression. That would be a pathogen that we would be more concerned about. This is, again, that example of Citrobacter. So on the left, top left, you see Citrobacter cosseri, so really pan-susceptible. The key thing that we have to educate on is intrinsic resistance. So that ampicillin you see is resistant. That's largely due to kind of narrow spectrum beta lactamase production, but not necessarily inducible AMP-C. And it's very low risk to overexpress AMP-C. So we should be treating based on susceptibility versus something like Citrobacter frundii, which is identified as a high risk for overexpression of AMP-C pathogen. You see the resistance already kind of indicating AMP-C with ceftriaxone, ceftaz resistance. So really preferring something like a cefepime or meropenem. In this case, it's urine, so we can use a quinolone or Bactrim potentially. But again, sharing this information with clinicians and prescribers is really important to help prevent overuse of broad spectrum agents. And then getting this information with the lab and making sure that it's accurate is really important. This is just another example. So I don't know if everybody struggles with this, but Serratia is the bug that we have the hardest time convincing people not to treat like an AMP-C. Again, probably historically with spice being the first letter, it's the one everyone remembered apparently. But you see here again that intrinsic resistance to cefazolin, pan susceptibility otherwise. This patient was actually treated with ceftriaxone for a day and then escalated to cefepime. And so we get the susceptibilities back. You can see this is February 18th. 5 days later, patients continued on cefepime. Susceptibilities remain the same. 10 days later from initial culture, susceptibility is exactly the same. So again, sharing this information and sharing this message that it's unlikely to induce this AMP-C response and resistance is really key to, I think, making clinicians feel comfortable to use susceptibility-guided agents like ceftriaxone in this case. So other kind of CLSI updates and limitations of this rapid diagnostic platform. So one that we struggle with also is cefazolin. So cefazolin per CLSI has different breakpoints for cystitis versus non-cystitis. So I'm sure all of you are familiar, but the cystitis breakpoint is less than or equal to 16. And then for kind of, non-cystitis, deep-seated infections, it's less than or equal to 2. However, our Vitec card, the lowest dilution that it goes down to is less than or equal to 4. So again, 1 dilution higher than that CLSI breakpoint. So what we had to do at Northwestern is really take a look at our data and our outcomes to see what our susceptibility rates were, rely on our PK/PD experts, i.e. the pharmacist on our team, to really help kind of suggest that for hemodynamically stable patients, an MIC of 4 with cefazolin for an intra-abdominal infection or a pyelo, when dose optimized, should be reasonable. And so we consider it susceptible in those cases. So this is something that I know a lot of labs struggle with because we're not always able to get it down to the lowest MIC. So again, just one of the challenges when you're dealing with different platforms for interpretation of these susceptibilities. Speaking of, so updating these breakpoints, so this changes, every few years, it seems like. This article from Van and colleagues describes some of the recent changes from 2010, 2012, 2014, and 2019. The one I wanted to highlight were the quinolones. So again, that kind of updated breakpoint in 2019. There tends to be a significant lag time between these updates and then implementation of the standard. So Simner and colleagues performed a survey of about 1,500 labs and found that 38 to 71% of US labs were using these obsolete breakpoints, compared to about upwards of 40% of international labs. So definitely something the US struggles with a bit more, it seems. It's important to highlight kind of the barriers that they mentioned in the paper too. So manufacturer-related issues, so not having the card updated and available for testing, and then lack of resources to perform this internal validation. So those were the biggest ones that stood out. And we definitely, again, struggle with the quinolones, which we'll talk about here. So for our interpretation for Cipro, so the breakpoint is less than or equal to 1 per Vitec and 2 for Levaquin. However, with, like we talked about, CLSI update, it's 0.25 and 0.5 for Interbacterialis, and then 1 dilution higher for Pseudomonas. Because of this, we've seen some patients, inappropriately prescribed a quinolone for a deep-seated infection. So we added a result comment. So this is something that, again, in partnership with the lab, stewards can help promote optimal use and selection of these agents. So we added the comment that said for deep-seated infections outside of the urine, an MIC greater than 0.25 for Cipro or 0.5 for Levaquin suggests clinically important fluoroquinolone resistance, and alternative therapy should be recommended. So this is something that is going live currently for us. Again, limitation of Vitec 2 card, and I know this is a big one that people struggle with. And then really using our PK/PD expertise to help determine when quinolones may still be preferred. So you can see here the serum concentrations are a lot lower compared to the urine concentration, so hundreds of times lower. So if we get a level, using Levaquin as example, so a dose of 750 milligrams orally gives us a level of about 8, maybe we have 5-ish available unbound in the serum. When we look at our PK/PD target, so we want about 10 times the MIC in terms of our peak. So if we have 5 as a peak, that MIC needs to be 0.5 or less. Same thing with Cipro, but then urine, you can see with a dose of Levaquin 500, you're getting 500 to 800 milligrams per deciliter in terms of, or micrograms per deciliter in terms of concentration. So you're able to identify opportunities to really still consider using these agents when they're maybe intermediate or resistant, but you don't have a lot of great options otherwise. So using kind of our PK/PD skills here to help guide primary teams when these agents may still be feasible to consider. This is one. So this is a more recent update actually from January of this year. So the Pip/Tazo guideline CLSI guidance in terms of MIC cutoffs have been lowered from 16 to 8. And they also give a comment that really should be considering use of extended interval here and higher doses. So the 4.5 given over 3 hours or 4 hours. This is based on the results of the Marino trial, which demonstrated that Pip/Tazo was not non-inferior to meropenem for the treatment of gram-negative bloodstream infections. They identified some issues with the precision of MIC testing, as well as some beta-lactamase resistant or beta-lactamase genes being expressed. And so this led to the kind of lowered breakpoint to promote these optimized target attainment goals, and then hopefully identify this better or better identify resistant isolates. So again, really being a little bit more conservative, because in Marino we saw things that were initially called, 16 had MICs of 32, and that may have led to inappropriate use of Pip/Tazo and poor outcomes as a result. So this is something that I think a lot of labs will have to adjust to going forward. So selective reporting, this is something that should be done in terms of best practice to really only report things that are informational, they're actually usable for the clinician, and it's specific to whatever the differential is. So not routinely performing things, susceptibility on bacteria that are contaminants. So don't work up every coag-negative staph. That's something that we should be doing, unless it's 2 of 2, persistently positive, patient's hemodynamically unstable, and then we just request that to be done. Not performing susceptibilities when we know there's intrinsic or expected resistance. Certain bug-drug combos, so we're not running daptomycin susceptibilities on respiratory isolate. So I think that's just a no-brainer, good practice. And then things like if an agent isn't on your formulary, so we don't have ertapenem for inpatient use really, so that's not included in our report to help persuade people against using that agent, and then selecting our preferred carbapenem, which is meropenem. There are other things that we can do to help influence prescribing practices of certain nudges and comments that we can include in the results to help guide clinicians towards appropriate selection of therapy or lack of therapy in these cases. So Susan Davis's group at Detroit Medical Center, so they conducted a quasi-experimental study with long-term follow-up to evaluate the impact of a culture report comment to influence antibiotic prescribing. So they stated, as you can see here, commensal respiratory flora only, no Staph aureus, no MRSA, no Pseudomonas. This resulted in a huge de-escalation and huge win for stewardship. So anti-MRSA and anti-Pseudomonas therapy was de-escalated in about 80% of patients, and this was sustained throughout several years in terms of follow-up. This is a straightforward, free intervention to really reduce the concern and hesitancy to de-escalate. And again, promoting optimal therapy to hopefully ensure improved outcomes for our patients. Another thing that we can do is make sure that, again, our reporting is useful for the clinician. So one thing that we have struggled with is we see that because we report ceftaz susceptibility for Stenotrophomonas, people were still using ceftaz even though we know there's intrinsic resistance with beta-lactamases, so L1, L2, to really render ceftaz kind of inactive. And it's not recommended per the IDSA guidance, again, from last fall. So using that information and then also partnering with the lab to remove this susceptibility from being reported. So this is something that we hope to do to prevent major errors where patients could be treated with ceftaz and then, it's ineffective therapy. So this is, I think, one thing that I would definitely encourage everyone on the call to take a look at and ensure that this is happening at your institution. Another just quick example, so interbacteriales, so the breakpoint for Bactrim or trimethoprim sulfamethoxazole was lowered from 4 to 2. One thing that we struggled with actually was our new Vitek cards reported it instead of like 1/19, 2/38, they did the combination of those two numbers. So it just says less than or equal to 20, which would indicate 1/19 for the trimethoprim and sulfamethoxazole components. That led to some confusion. So that was education to our pharmacists who then, shared the message with their primary teams. And then really feeding the end user with that local data. So this change going from 4 to 2, what do we expect to be the impact? So are we going to have to stop using Bactrim in these cases? So we really took a look and using partnership again with the lab and our EHR, we found that it really wouldn't change our susceptibility rates very much for these organisms listed, and most of them tended to be at either the lowest or highest MIC. So again, really providing that assurance that this is what we should be doing, and we can continue using this agent based on the results that we have. Another thing that we can consider using is cascade reporting. So this is something that's typically automatically added on by the lab, and then you may have to call, in our case, call the lab to get that result reported. So this is something that you can use or think of as kind of like reflex susceptibility testing criteria. So we have it for some of our multi-drug resistant gram-negative antibiotics. So things like cefiderocol, ceftazidime, ceftotazo. So ceftotazo and ceftazidime are actually included in our Vitec card. So we typically won't report it if they're susceptible to cefepime, piptazo, meropenem. However, that's something that could be called upon the lab to release and then share that information if a patient had intolerance or polymicrobial infection, et cetera. Cefiderocol, obviously, that's a bit more of a challenge. But hopefully knowing that this cascade reporting is happening can result in reduced time to susceptibility information being available. Again, that reduced communication burden on both the clinician part and the lab. And then it provides a standard process to avoid any confusion and lack of follow through. So really even just like adding a comment that says additional susceptibilities are being performed allows people to be more informed of what's happening. And hopefully, again, improve kind of the ordering, interpretation, and then subsequent antibiotic decision making that's happening. This one is, again, another example of nudging. So really using nudging to modify the antibiotic choices to improve decision making. So this was a study conducted in Ontario, nearly 115,000 elderly patients that were in the outpatient setting. So they assessed what was the impact of reporting susceptibility for a specific antibiotic. And they found that prescribers were 3 times more likely to select an antibiotic that showed susceptibility. So when that was reported, they were more likely to choose it for definitive therapy compared to an agent that wasn't reported. Although, susceptibility is really probably expected. So if you look at the bugs here as E. coli, Club pneumo, Proteus mirabilis, so all of these should be fairly susceptible to early generation cephalosporins and immunopenicillins. You can see, however, when those agents like cephalexin or amoxiclav are reported at rates, kind of hard to see at the bottom, but roughly 30% of the time. So labs were only reporting it about 30% of the time compared to about 98% of the time with agents like nitrofurantoin, Bactrim, quinolones. Those beta-lactams were used at a much lower rate. So even showing that result leads to people being more likely to use it, even though we know that the other beta-lactams should still be active in this case. This is just another example of clinician education for you all. Again, ASB, I think, is something that we struggle with daily, it seems, and I think cannot educate on this enough, but really highlighting, what is best practice here. So not sending urine cultures without symptoms being present, even if it's an ESBL organism or there's drug resistance, doesn't change that. There should still be symptoms, or unless they fall under one of those buckets, pregnancy, urologic procedure, or transplant within the last month. What about pyuria? So pyuria, as we know, is not a great marker or indicator of an infection. So really just showing that inflammation. We can use it as maybe for its negative predictive value. So if it's not positive or not present, maybe we can use that to withhold reflex culture, which is a good thing. But just because it's positive, that could be the case in a number of scenarios. So not always indicative of a urinary tract infection. So again, educating on that. And then confusion is the biggest one. Really bacteriuria, limited to cystitis or bacteria in the bladder itself should not cause confusion. Without that, upper tract disease, hypoperfusion to the brain, So no need to really start antibiotics in this case, and really should look for other symptoms or other reasons for that confusion, medications, comorbidities, et cetera, especially in our more kind of vulnerable elderly patient. And then I'll wrap up with some partnership. So really kind of, as I've talked about all day, but stewardship is a team-based approach and should be a team sport. So really providing education, institutional guidance, and open communication are keys to making sure that, both the micro and stewardship side are successful. So institutional guidance. So this should be something that's readily accessible by your end user, i.e. clinician, as well as your stewards and your micro professionals. So we have an open access website. You can get to it on your phone. Our prescribers really like it because they can pull it up, in between patient rooms. Patients can access it too in case they have questions. So that's something I think that stewardship is also heading towards in terms of patient education and getting them involved in shared decision making. For communication, I think it's important to set up like regular meetings that include all of the kind of stakeholders that we discussed. So micro labs, stewards, hospital epi, and infection prevention. We have a standing meeting every Monday to help, identify issues and kind of initiatives for that week. Also frequent micro rounds. So just interfacing and building that rapport with your teams because, we're in the basement. So it's sometimes hard to get over to the micro lab and we don't interact as much as we should, but having those set micro rounds at least gives us an opportunity to interact. And then make sure that you do have micro lab presence and representation on your P&T committees. So our lab director is on P&T and she's phenomenal in terms of helping us decide, interpretation of tests and which tests should we be evaluating to bring on. So huge help there. And then really continued education and evaluation. So, looking back at your practices and processes to hopefully identify potential endpoints to either study or optimize patient care. So things that you can potentially look at would be time to effective therapy, i.e. a lot of the data with the blood culture, biofire, et cetera. Time to discontinuation or de-escalation, time to ID consult, and 30-day readmission or mortality. So those are things that are set out by an ICID paper, which Carrie Bauer did, which is highlighted there. But yeah, definitely requires evaluation of the practices that you're doing. This is our stewardship website. So again, it should be readily accessible and something that, you shout from the mountaintop for clinicians to use. I think every presentation refer to it just to re-educate and make sure people are using it. But we also want to keep it updated and make sure that it's user-friendly and the information that's there is actionable. So these are things that we have, obviously antibiograms, and then specifically breaking out into unit and source-based antibiograms. So that's something that's recommended per CLSI, and again, requires, large partnership with your lab colleagues. And then prescribers really appreciate, I think, organ-based guidance in terms of clinical pathways, particularly related to durations of therapy. So we recently surveyed some of our pharmacist colleagues, and they, that is their number one kind of issue as stewards. So that's something that we hope to address. And obviously, we're getting more information that shorter therapy is equivalent or better in a lot of cases. So including that in your guidance is key. So again, just having some place to share this information to ensure that clinicians are aware and kind of promoting the practices of stewardship. With that, I will wrap up and take any questions, but thank you so much for your attention.
Thank you so much, Dr. Moore. I saw there were some questions, but Jim Rhodes has been answering many of them.
Yes. Thank you, Jim. Jim is a brilliant colleague at Northwestern and Midwestern. Appreciate the support. Are there any unanswered that I can help with?
There is one here from Allison. Any lessons learned on how to effectively communicate interpretation of test results and treatment recommendations, especially for PCR plus toxin? Their hospitals will be adopting the same testing algorithm in a few months, and they're beginning to plan the education piece.
Yeah, so that's something that took months for us. We did kind of a roadshow of education. So we went to a lot of the high use areas, HEMONC, ED, solid organ transplant, to really make sure that those prescribers and ordering users were aware. And then again, using kind of the EHR and leveraging that to include the information, as well as whatever, intranet or internet website that you have, to help share that. Another thing that I think is underutilized are the pharmacists. So use your non-ID, non-stewardship pharmacists to really be extenders of that message. So that in combination with just repeated education and that clinical pathway that I showed worked for us. It did take quite a few months, and we're still seeing a number of patients that are being treated. They're PCR positive, toxin negative, so something that we struggle with, especially in our HEMONC population, which is somewhat expected. But yeah, I think rely on other institutions that have done it before. Obviously, our documents are open access, and feel free to reach out to me if I can help in any way. But I think it really is just that collaborative approach with the lab, with your frontline clinicians, and with informatics and stewardship support, to really make sure it's a successful initiative.
Thank you, Dr. Moore.
Sure.
So in about 4 minutes, there is the next group of presentations going on, starting at 2:35. So if you're signed up for those, you can go to the sessions tab, and then you'll be able to find any of the ones there. Thank you all.
Great. Thanks so much.